Thank you so much for the kind introduction, and thanks for the opportunity to run through health economics this afternoon. I should first of all thank Emily Holmes, who I know is online as well, for assisting with the contributing slides to this presentation. It's very much a joint effort. And also, I know Deb's here, and so forgive me if I do overlap with anything that you presented previously. I hope that both the presentations complement each other and that there isn't any significant overlap. So this is a whistle-stop tour of what we do as health economists. There's a number of tools that we have available to us, methodological tools that we can apply in different contexts. And what I want to try and provide today is a flavour of some of the most commonly used tools that we use to help inform decisions on healthcare prioritisation. So my first slide then is an outline. I'll begin with a short introduction and then move swiftly on to the various frameworks that we have for economic evaluations. So how do we assess the value of healthcare interventions, health technologies, medicines, surgical procedures and such like. And we'll then move on to specifics on how we measure costs, how and which health outcomes do we measure and incorporate in economic evaluations, and then to look at patient preferences and ways in which we quantify people's preferences towards different forms of health services. Part 4 of the presentation will be a case study of an economic evaluation for treatments in epilepsy. And then I will run through a particularly difficult decision that relied partly on health economic evidence, but that should hopefully alert you to some important take-home messages, which I will then summarise in the final couple of slides. So economic evaluations then formally, they provide a framework for identifying, quantifying and comparing the costs and benefits of different options, different courses of treatment options or diagnostic or whatever the healthcare intervention may be. It clearly differs from an accounting exercise which considers only costs, in that this incorporates the whole notion of evidence-based medicine to also weigh up the differential impacts on costs versus the benefits that treatments can produce. Economic evaluations explicitly consider scarcity of resources, and key to this is the notion of opportunity cost. If there's one thing that you will remember from today's lecture, it'll be a definition of opportunity cost, which I have more formally listed in a forthcoming slide. But briefly, it is the value of the benefits foregone by not using health resources in their best alternative use. So if I use my £1 million to invest in a particular expensive treatment that may have marginal benefits in health benefits, then I would lose money and I would lose health, because the funds to support that intervention would need to have been found from elsewhere in the health system, and it could arguably be used to purchase more health improvements in other people elsewhere in the NHS. And so we need to consider any expenditure as health benefits which are foregone, because often there's no new money attached with healthcare spending decisions. There are 4 principal methods of economic evaluation, which are listed here. Cost minimization analysis is the simplest one in many respects, but it requires evidence of therapeutic equivalence between 2 or more interventions. And the classic example here would be the conversion from branded to generic medicines, whereby the health outcomes are equivalent. I know there are a couple of exceptions with particular treatments, but by and large, generic treatments would be bioequivalent and hence therapeutically equivalent to the branded originator. So the only difference between them arguably would be in relation to their cost. And logically, you would go for the least costly option, all else being equal. That would then represent a cost minimization analysis. If we don't have the evidence and we assume equivalence, then that probably isn't good enough. We need some firm established equivalence data to make the assumption that a cost minimization analysis would apply. It's more often the case, though, that treatments have differential effects on a given outcome. So if we consider treatments that may prolong survival, then the common measure of outcome would be years of life, that being a measure of survival. And so we could potentially compare them within a cost effectiveness analysis framework. So one treatment might be able to extend life by 2 months on average, and the other one 3 months. And there may be a differential cost between those two treatments. And so we can calculate the cost effectiveness in terms of the additional cost to extend life by that additional month. More often than not, treatments have impacts on more than one outcome. And arguably, you might say that everything we do ultimately is to try and improve health-related quality of life and survival. These being the two fundamental dimensions of health, how well you feel and how long you live. And the economic evaluation framework that considers these two is the cost utility analysis. And this predominates as being the economic evaluation method of choice used by NICE, the All World's Medicine Strategy Group, and other agencies nationally and internationally, increasingly so too. And finally, the fourth method listed here is the cost-benefit analysis, and this isn't used that often in health because it requires the difficult task of assigning a monetary value to the benefits gained. I've listed it here for completeness, but it isn't something that you would regularly come across in the literature. So you'll notice that each of these begins with the word cost, and the way in which costs are calculated, estimated, and measured are the same across all these analyses. What differs is the way in which we measure outcomes. So I'll begin with the practical slide on how we measure costs. But first of all, we need to be mindful of the different categories of costs. Broadly speaking, we have the direct costs, the indirect costs, and the intangible costs, and between them, these make up the total cost of care. Direct costs, well, let me begin with indirect first of all. Indirect costs are those associated with typically loss of productivity. So if somebody's off work because of illness for an extended period of time, and they're not contributing to taxation, and they're receiving sick pay, etc., then there would be an indirect cost through reduction in their productivity in the workforce. That would be a classic example of an indirect cost. Intangible costs are the more difficult to assess and to measure costs associated with the pain and the inconvenience of undertaking and going through with medical treatment. We don't often measure intangible costs in that sense. Neither do we often evaluate indirect costs. And the reason being is that the decision makers largely only have control over NHS budgets and not other forms of expenditures. And so the focus typically is on direct costs. And there are two components. There may be direct medical costs, which we're perhaps more familiar with, the costs of the intervention, the costs of different tests and procedures, healthcare professionals' time, GP visits, time in hospital, etc. And there may be non-medical costs. And these may be the costs of social care services and other potentially non-medically related costs. And it's these two, the NHS and the personal social services cost categories, that we are more likely to measure and report in economic evaluation. There are some subcategories here: fixed cost, which is sort of sunk costs that you need a capital cost to build a hospital, and then there's a variable cost of running the hospital over periods of time. So just to elaborate a little bit on those, direct costs would include these fixed and variable costs, for instance, and would typically include, as I've already listed, medicines, tests, clinic visits, etc., those being the medical costs, and also the non-medical costs, which would include travel to and from hospital, cost of healthcare, and also social services, which I haven't explicitly mentioned here, but it would be a non-medical costs nonetheless. The indirect costs then would be the productivity related, and they would represent the value of lost productivity due to sickness and absence from work. This is different, of course, from overhead costs. We need to be mindful of that. There are different terms used in economics than used in accountancy. So when we refer to indirect costs, we are not referring to overhead costs. And final category here is the intangible costs, but which are difficult to assign a monetary value. And they would include the examples I've listed in this slide. Now, which costs we consider for an economic evaluation depends on the perspective that we take. And the perspective is the point of view applied when deciding on the evaluation to be done, and it depends on who's making the decision. So if we take a patient's perspective, then perhaps we'd be less interested in any costs incurred to the NHS or any costs incurred by government, because it would largely fall upon patients' out-of-pocket expenditure. So if I were to take my own perspective as a patient and I might be seeking healthcare, then most things are free at the point of delivery. But if I were to purchase treatments over the counter in a pharmacy, for instance, then my breadth of costs would include that as an out-of-pocket expenditure. More often, we see perspectives being taken from the payer's perspective, which would be on a local level. It may be a hospital, for instance, or it may be on a larger healthcare system, i.e. the NHS, or potentially a societal perspective, which is the broadest perspective that can be adopted. A societal perspective would need to then consider costs extending beyond NHS expenditure, and it would include all of the cost categories I referred to earlier, including productivity losses due to a patient's inability to work. It would include also costs falling on other sectors, potentially education or legal aspects of, if there's any examples of treatments that would reduce offending rates, for instance. Just to add the importance of knowing the difference between marginal and average cost, we might say that the extra stay in hospital for a single night in a ward might be £500. So that would be the marginal cost. However, if the ward is full to capacity, then theoretically the marginal cost then shoots up to £20 million, because that would be the cost of building a new hospital ward or a new hospital ward extension. So while the marginal cost is 500 typically, if there's a need for a large capital investment, then for that additional patient who would be first admitted to that hospital or new ward, their marginal cost would be in the millions of pounds. So on average, if you take all this into consideration, the average cost might be 550, let's say. We often aim to quantify marginal cost, but the practical reality of it is we rely on average costs, which isn't too dissimilar from the marginal cost as illustrated here. Returning to opportunity cost, a cost pressure on a fixed budget healthcare system, for instance, by introducing a new expensive treatment, requires that other services are displaced or diluted. So people have to wait longer, the waiting list increases, maybe services are reduced in other parts of the health system, and they represent the opportunity cost of investment choices in new and expensive treatments. The opportunity cost is the value of those displaced services in terms of the health which is foregone. And when we think about cost effectiveness thresholds, so NICE, for instance, specifies a £20,000 to £30,000 per QALY threshold for cost effectiveness, then in some ways they represent a proxy of the opportunity cost. And so I think this slide is quite important for you to try and understand and perhaps remember in time to come. Now, how do we practically measure costs? Then there are several ways. We need to, first of all, specify which costs are important to our intervention. If it's a primary care-led intervention, then obviously a GP surgery cost would play a significant part, and maybe hospital admissions would be less important. However, even if admissions were rare, they do incur much higher costs, and so we need to make that balance of ensuring that we're capturing the right cost categories. There are various methods we can derive to estimate cost and resource use. We can simply ask the patient by administering a questionnaire or maybe a patient diary. Depending on the circumstance, it may be more appropriate to ask the patient's carer. We might include, within a research setting, we might have a CRF whereby we would capture data in a pre-specified data collection template within the case report form, and that maybe would be recorded by a healthcare professional, research nurse, etc. We can rely on routine data and access such registries as SAIL, perhaps, or via NHS Digital for England. We can access individual patients' notes. Obviously, this is facilitated when these are electronically compiled. So there are various different ways in which we can estimate people's use of healthcare resources and assign a cost to those. Again, in different contexts and different countries, we may be able to, for instance, in the USA, rely heavily on insurance claims as being a proxy for the costs of healthcare. So I'll move on now to discuss outcomes, and those outcomes of relevance and of interest to health economic evaluations. We can categorize outcomes in various different ways. We would be very familiar in clinical studies to assess the efficacy and effectiveness of healthcare interventions, and typically they would include a disease-specific measure of benefit. That may be an objective measure, or it could be a subjective measure, but it tends to be disease-specific and sensitive to change, or when one treatment is more effective than another. I've referred already about the appropriateness and the need to consider health-related quality of life, and also life expectancy or survival benefits. And there are various ways in which we could measure quality of life. One of which we prefer in health economics is to measure health utilities, and I'll come on to that in a moment. With cost-benefit analysis, of course, we can measure benefits in monetary value, but there are difficulties in doing so. So then, utility. Economic measure. Utility is an economic measure of preference for a good or a service that represents the overall satisfaction, or when it relates to health, it's a measure of people's well-being, how well they feel. And effectively, we put this in a scale of 0 to 1. It seems very simplified, but it's a systematic and it's theory-based valid approach to try and quantify people's utility or people's health. So utility itself is based on a theory that individuals make rational choices and can choose or trade between multiple aspects of health that's been generated through the use of an intervention. And we typically anchor utility at 0, representing death, 1 representing perfect health. And there are various ways in which we could try and estimate utility. The most common approach is by administration of a questionnaire. This is an example of one, the Euroqual 5D5L questionnaire. 5D represents the fact that it has 5 dimensions rather, representing mobility, self-care, ability to perform usual activities, pain and discomfort, and anxiety, depression is listed here on the left. And each of these has 5 levels, ranging from having no problems at all to having significant problems. For instance, for mobility, they would have no problems in walking about, ranging through to unable to walk about at all. And depending on how people respond to this questionnaire, we can then map that across to public preferences of the general society to identify a utility score. I'll show that in my next slide. Before I do so, on the right-hand side here is a visual analog scale that asks people to represent their health on a given occasion from the worst to the best imaginable health on a scale of 0 to 100. That isn't preference-based. There's no modification to that. It's just a raw score of how people quantify their health on the simple scale of 0 to 100. So if I return to the questionnaire on the left-hand side and imagine somebody who has reported perfect health, they would indicate no problems in any of the 5 dimensions, and that would correspond to a health utility of 1. However, imagine somebody then who is in a less perfect state of health, that they would have a disease that would reduce their mobility, impair their self-care, their ability to perform usual activities, and they would be associated with a high level of pain and discomfort and extreme anxiety and depression. Not a particularly good state of affair, and their corresponding utility value on this scale of 0 to 1 would be 0.27, and that value is derived from large societal studies whereby they undertake specific experiments to trade off these particular dimensions in health to understand how people value being in a given health state. So that would represent a poor health state. I should add for completeness that it is possible to have a health state which is worse than death. So somebody responding with the worst score of 5 on each of these 5 dimensions has a value which is a negative number, health utility of -0.28. And what that in effect represents that they would rather be in a state of death, as in not be alive, than they would be in this particularly severe state of health. We just need to be mindful that that is a theoretically possible state of affairs. Now, you'll have heard, I hope, about the quality adjusted life year. This is the metric by which we calculate cost effectiveness within the cost utility framework of economic evaluation. And the quality adjusted life year is the integral of utility over time. So in effect, it's the area under the curve when plotting utility against time. This is widely used to make comparisons of different modalities of healthcare. If we represent it graphically, then this plot indicates quality of life on the utility scale. On the left-hand side, there's a vertical axis between 0 and 1, and then time across the x-axis. And you'll see that the current standard of care has a good quality of life initially, but there's some episodic reduction in quality of life that then periodically goes into remission. But on the third occasion, there's a gradual decline, at which point the patient dies. So that would be a health profile of somebody with existing treatment. The new treatment here both improves people's quality of life and also prolongs their life expectancy. And so the area in between these two figures represents the quality adjusted life years gained, QALY gained. And the NHS is willing to pay in the order of £20,000 to £30,000 for each QALY gained. So that would be the way in which NICE would make its decisions. And it's an important metric, obviously, that underpins cost utility analyses. Right, so I'll move on now. I know this is rather quick. I'm against the clock. Please do, feel free to send questions that you may have by email, or maybe there's an opportunity at the end of the difference in QALYs. While they focus on healthcare outcomes, we also need to understand the value or the utility people place on healthcare processes. So, for instance, if I were to have a surgical procedure and that would require me to be admitted for maybe 2 or 3 nights, then I might arguably have exactly the same health outcomes if it were a day case surgical patient. So the outcomes would be the same in terms of the health outcomes, but the process of care would differ tremendously. I would be in and out within a day as opposed to having to stay for 2 or 3 nights. So that distinction between process and outcomes is important. And within our toolkit, we have other methods to try and quantify preferences towards processes of health care. These would be typical examples and applications where we would want to consider these sorts of aspects. So, for instance, different skill mix. So could a potential service be delivered equally in terms of health outcomes by senior versus more junior healthcare professionals, provided the outcomes would be comparable? I've already mentioned inpatient versus day case. Another example may be treatment face-to-face versus some form of an mHealth intervention where that's done remotely. And trade-offs between waiting time and provision of information, those sorts of things. So these are different service configurations that could be assessed using a preference elicitation methodology. We could also look at screening programs whereby there may be some value of knowing that goes beyond just understanding the impact on health outcome. One approach is the discrete choice experiments that were developed in the 1990s to elicit views in healthcare. And these are based on the idea that goods and services are described by characteristics. So we refer to these as attributes. So for an inpatient versus an outpatient surgical procedure, the attributes may well be something along the lines of time to recovery, the pain experienced, the mobility following the surgical procedure, the potential risk of hospital-acquired infection, arguably. So they could be relevant attributes to that sort of choice that somebody may have by being an inpatient or an outpatient. Then we need to assign levels to each of those attributes. And so, for instance, whether there's a risk of acquiring an infection, it may be a binary choice of yes or no, or it may be a probability. If it's to do with pain, then it could be mild, moderate, or severe. So there are different types of ways that we can assign levels to the various attributes that we choose. This is an example of a pain clinic. Two service configurations, Clinic A and Clinic B. For Clinic A, obviously, in this instance, there'd be a longer waiting time to see a doctor. Once you do see the doctor, you have a shorter appointment, but you do get to see a specialist team as opposed to a generic team. The cost would be equivalent in both. And we would ask people this hypothetical scenario as to which might be their preferred option. And if they ticked against Clinic A, then we would repeat this in that same individual with a different mix of levels for each of these four attributes. And we might repeat that 10, 16 times typically. And when you do that type of experiment over a large number of people, then we can work out on average how many minutes of appointment time are they willing to trade against a longer wait, or those sorts of questions. So discrete choice experiments is a really useful quantitative tool to try and understand people's preference towards one attribute of a pain clinic versus another. And so we can design a clinic that could maximize people's preferences. So it may need to be a specialist-led clinic with a long consultation time, but a particularly long waiting list time. As an example, that might be the optimal configuration for a pain clinic. So discrete choice experiments, then, just to reiterate, are a useful method to try and understand different service configurations and different ways in which people have a preference towards process-related outcomes. They can be used to quantify then the relative importance of the individual attributes. We can also try and, if we have cost as an attribute, then we can identify the willingness they are able to trade between different attributes in terms of willingness to pay. So we can try and quantify people's willingness to pay for a given unit change in any of the other attributes. And we can use the discrete choice experiments to calculate the overall utility score of different combinations of attributes. There has been some work to try and incorporate these utility scores within economic evaluations, and so to provide the cost utility approach based on a discrete choice experiment. Right, so next I will run through a case study, which is there's some elements of reality in this one, but it's been simplified for the sake of trying to squeeze it into this presentation. But this is an example of an economic evaluation where we are comparing two treatments for the management of epilepsy. And the approach that we're adopting here is a modelling approach. This isn't a clinical trial-based analysis, but it's using an economic model or a decision tree. And the question here is whether carbamazepine or lamotrigine, which are two anti-seizure treatments, which it represents greatest value to the NHS, which is most cost effective. And we could represent this decision as a tree, and it is literally, it will look like a tree. You've got the patient who is eligible for either of these treatments, and there's a decision to be made, and that's conventionally represented by a square in one of these diagrams. And then the choice is between lamotrigine or carbamazepine. That's linked with a circle, which denotes a probability of something happening. And what's happening here is the risk of an adverse drug reaction. The work which underpinned this piece of work, Catherine Plumpton, my colleagues at Bangor, was leading on. The focus very much was on avoidance of adverse drug reactions, hence the focus here. So lamotrigine carries a probability of risk of adverse drug reaction, as does carbamazepine. But they both are obviously effective in reduction in seizures. And if we consider remission from seizures as being 12 months of seizure freedom, then treatment benefit can be represented dichotomously, for simplistic reasons here, that people either are in remission or they're not. And if we consider this analysis over a 12-month time horizon, then this can be used to inform our decision as to whether lamotrigine is more cost-effective than carbamazepine. We would typically identify the probabilities of each of these branches of the tree from the medical literature. So we would have clinical trials, perhaps comparing the treatments. We would have other complementary data sources that would perhaps provide reliable estimates of the probability of adverse drug reactions. So in this instance, lamotrigine is less effective than carbamazepine. It has a lower probability of inducing remission from seizures, but it has a lower probability also of adverse drug reactions. You might say lamotrigine is less effective, but safer. And I guess from a risk-benefit approach, we would need to understand whether that additional benefit of carbamazepine is worth it, given the additional risk of adverse drug reaction. Anyway, these are the sorts of probabilities that we would identify from clinical trials and meta-analyses of clinical trials. We would also estimate costs, and these could come from routine data. In this example, all this came from a single clinical trial, whereby the 1-year cost of treatment with carbamazepine that would include clinic visits in addition to treatment costs, just short of £300. Lamotrigine is more expensive, £550. There is some risk of adverse drug reaction, and there is a cost of managing an adverse drug reaction that we quantified as being £820. And of course, there is a cost of managing epilepsy, which is not controlled. In other words, where people are still experiencing seizures, they may require referral to a neurology clinic or additional attendance to hospital for whatever reason, and such like. So now we have two components of the evaluation, which are the probabilities of clinical events, the costs, and the third one for completeness are the health state utilities. So being in complete remission is associated with a utility score of 0.84 for people being prescribed carbamazepine. Slightly higher utility, this is directly from the clinical trial, of 0.87 for people being prescribed lamotrigine. When people experience epilepsy, so they experience seizures and are taking carbamazepine, there's a significant reduction in utility going from 0.84 down to 0.54. And similarly, there's a reduction for those being prescribed lamotrigine who do not have sufficient disease control. There's also a disutility. This isn't a state worse than death, but this is a disutility. It's a number that we need to subtract from the other numbers above it. So people experiencing a mild adverse drug reaction, we need to subtract 0.09 from the above utility values. So they would be the inputs to our decision analytic model, and we would run that model over a period of 12 months. So here we are, we return to the model in this diagram, and we'll start to populate it with some probabilities in the first instance. So with lamotrigine, there is a 4% probability of experiencing an adverse drug reaction, and there is a 33% probability of being in remission. They are two independent probabilities, so the chance of being in remission does not depend on whether somebody has experienced an adverse drug reaction. If we look at the carbamazepine branch of the tree, the probability of adverse drug reaction is just below 8.5%, and the probability of remission is 38% of 0.38. Now, obviously, if they are the probabilities linked with yeses on this diagram, then the probabilities linked with no is simply 1 minus that corresponding number in each case. So somebody being prescribed lamotrigine has a 96% chance of not experiencing an adverse drug reaction, followed by a 33% chance of seeing clinical benefit in terms of seizure freedom in 1 year. Right, we can then multiply these values to understand the proportion of people in each of the 4 outcome categories following either treatment. And we can see the distribution. We should ensure that these numbers add up to 1, so there's only a 100% probability linked to the 4 possible consequences for each drug. And we can see that the majority of people being prescribed either drug would indeed have no adverse drug reactions and no benefit from treatment. Okay, or at least it would not have full 1 year freedom from seizures. The second most popular category would be those who do not experience an adverse drug reaction, but do have remission from seizures, and that's in the order of 32% with lamotrigine and 35% with carbamazepine. So that maps out the probabilities of moving down different pathways of care and experiencing different types of events. And this is a description of each of those pathways. And linked to that from my previous slide would be costs. So, for instance, that very top branch, if we follow that through, lamotrigine is being prescribed, they experience an adverse drug reaction, and they are in remission. We would need to add the costs of 551 and 821. There's 0 cost for being in remission, but there is a cost of not being in remission, which would represent that second branch, where we also have to add £1,151. So for each of these branches, we add up the costs as we follow that pathway. So here we are. That's the same data transposed to my next slide. We add them up. This is the total expected cost of each branch of the tree, and we know what the probability of movement along each branch of the tree is, And so we could multiply those two values out to estimate in the final column there the total cost, the total expected cost associated with each branch of the decision tree. So this is the weighted average cost, and it's been weighted by the probability of that cost being incurred. So we have a cost, total cost associated with each branch. We have a probability of patient movement along that branch, and we multiply one by the other to get the expected costs. And they range from £18 to over £1,000, depending, in the case of lamotrigine, whether they're in remission or whether or not they've experienced an adverse drug reaction. So here we are, returning back to the tree. We now need to identify the utilities associated with each branch. So again, the very top branch, people being prescribed lamotrigine and experiencing adverse drug reaction, but in remission from seizures, they would have a utility of 0.87, from which we need to subtract 0.09, which is the utility or the disutility associated with experiencing a mild adverse drug reaction. And again, we do that for each and every one of these branches. And in the same manner as in the previous slides, we add these up, and that then provides you with the expected utility of each branch along the tree. And in exactly the same way, we need to identify how many people went down each of those branches as a proportion and multiply them out. So this then gives you the expected utility associated with the 4 branches corresponding to each of these 2 drugs. And again, the greatest number of utilities accrue in those patients who are not in remission with either drug. So it's about 0.39 for lamotrigine, 0.31 for carbamazepine. The fact that people experience an adverse drug reaction and are in remission does not contribute a huge amount to the overall utility value. And that's largely because the probability of experiencing an adverse drug reaction is low. Right, so let's pull all this information together. We have, for lamotrigine, we have the 4 branches with their respective costs and utilities, which we now can call qualities because it's over a 1-year time horizon. That's for lamotrigine, and we can add these up. So the overall expected, sort of the weighted average cost managing people with lamotrigine is in the order of £1,350, and the expected qualities over the 1 year is 0.69. For carbamazepine, we do exactly the same thing. The overall expected cost is £1,080, and the qualities experience is 0.64. We can work the difference between these 2 treatments in terms of their costs, and similarly the difference between them in terms of qualities. Difference in cost, £270. Difference in qualities, 0.05. That gives us then the information needed to calculate cost effectiveness. The incremental cost effectiveness ratio, the ICER, is given as the difference in costs divided by the difference in qualities. So 237 divided by 0.045. That gives you a value just short of £6,000 per quali. That's well within the NICE threshold of cost effectiveness, which is £20,000 to £30,000 per quali, and so lamotrigine would be considered to be cost effective, even though it is more expensive than carbamazepine overall. So just to recap, I've taken you step by step through a simple cost effectiveness analysis that considers the adverse drug reaction rates and the clinical benefits of 2 corresponding drugs for epilepsy, each of which are associated with differential costs, differential probabilities of effectiveness and harm, and different utility weights based on the health outcomes experienced. We can synthesize all that evidence to a single ratio, which is the incremental cost effectiveness ratio, or ICER for short, and that's the metric by which NICE makes decisions on cost effectiveness. Right, I will run through now a difficult decision and maybe a little bit of audience participation if that is possible on Teams. It's in relation to a treatment that was appraised by NICE for a rare inherited disease, Morquio A syndrome. It affects 1 in 200,000 live births, so it's very rare. It's characterized by abnormal development. The bone, particularly the spine, is affected. People or children present with a bell-shaped chest, with abnormalities in their back structures. They have hypermobile joints, and they tend to be particularly short in stature. They also have a limited life expectancy, with average life expectancy of about 25 years, though that can vary, and some people experience normal life expectancy. This would be a patient with Morquio A syndrome. Now, a drug developer introduced an enzyme replacement therapy, L-sulfase alpha, which was shown in randomized controlled trials to be effective for the management of patients. They did wonders to recruit 176 patients with this particularly rare condition, and they tested the drug with 2 outcomes in mind. The first being the walking distance in 6 minutes, which is simply how far in meters can people walk in a period of 6 minutes compared with placebo at baseline and then after 24 weeks of treatment. That was the primary endpoint. The secondary endpoint was how many steps could they climb in 3 minutes. So it's a simple task of putting on the stopwatch and simply counting the number of steps that people could walk up. So these are the results of the primary outcome. At baseline, people could walk over 200 meters. After 24 weeks, there was an increase in the drug group, 37 additional meters of distance covered, compared with only 14 meters in the placebo control group. So that was a difference of 22 meters, which was statistically significant. So there was benefit. They could walk an additional 20 meters, which represents about a 10% increase on their baseline distance covered. Now, the secondary outcome, number of steps climbed, was no difference between groups. There was one additional step that they could climb in 3 minutes, but that was not statistically significant. So then my question, and this is the drug, I guess my question, I guess it's quite difficult to have feedback here, but I mean, what might you think would be the a reasonable price for treatments that could extend people's distance covered by 10%, no improvement in walking up the steps, no evidence at all about survival benefits or other aspects of quality of life. Now, I guess answers on an envelope, because I don't think it's going to happen on Teams. But I can tell you that when I presented this in a teaching presentation last week, there were 3 or 4 suggestions ranging from about £5,000 per year to about £20,000 per year for this treatment, and the actual price is nearly £200,000 per year, and that would be over the 25-year period per patient, of course. So that's a significant sum of money, and you might ask, well, you know, is that good use of NHS expenditure from a health economics perspective? And arguably it isn't, but you know, there are other equity considerations, etc., that need to be taken into consideration. NICE made its determination and recommended L-sulfase alpha for people with this condition. So it received NICE approval, despite it being nowhere near cost effective based on conventional metrics. So obviously other factors play a part, and that brings me to my final slide, just to highlight some key points. If you ought to think about costs and any expenditure as health foregone. So any choices and decisions made about writing individual prescriptions to making public health policy decisions, there's a cost to that. And the way that we ought to think about that cost is in the benefits lost elsewhere in the health system. I've hopefully given you a flavour of some of the tools that we have within the health economics toolkit. And this is quite extensive and quite adaptable to different contexts and decision making. But importantly, as illustrated in that last case study, health economics is about informing decisions. Certainly, it's not about making them. So I will end on that note and stop sharing my screen, and happy to invite the audience to ask any questions.
Thank you very much, Dyfrig. Can we open up to some questions? Maybe perhaps people could turn their cameras on so that we could see them, and they can ask us some questions. There must be some questions, surely. Wonderful. Hello. Hi, Emma, Ailing, Zoe. So Emma's got a question for you.
Thanks, Dyfrig. I found that really, really helpful as somebody who's brand new to this. My project looks at changing the diagnostic pathway. So I'm not having an intervention which is a treatment. And I'm just wondering if this sort of rationale or these principles can be easily applied to changing a diagnostic pathway. It's for heart failure. And if there is anything you could recommend in terms of something I can read to find out a good example of how to assess the added value of changing the diagnostic pathway.
Yeah, it's you're quite right. We've done. I've got a study ongoing at the moment, which is also looking at diagnostic pathways in heart failure. And the way we are interpreting it is that any change in diagnosis in terms of additional cases being detected, or arguably additional false positives, and we need to think about these things in terms of sensitivity and specificity of the diagnostic test if it's a particular biochemical test that's of interest. But then that leads to a consequence, and it could be a change in treatment, or it might cause a change in practice as a consequence of diagnostic pathway. So I would argue that there would be a cost consequence and a benefit or harm consequence to any upstream change that we would have. So this approach, it would be suited. It could consider the various options available, and I can try and dig out some papers and send you those. What I'll do is put my email address also in the chat, and maybe you can drop me an email just to remind me to do that.
Thank you. Are there any other questions from anyone? Ailing.
Sorry, I'm on a phone. I couldn't work out how to raise my hand formally. I was just a bit confused. You mentioned about I can't remember who you said is paying for quality years or quality. I can't remember what the phrase was. And you mentioned quality. Sorry, yeah. What can you explain that? Who you said that they attribute a cost to that? Is that per person, or how does that work?
Yeah, in effect, what we provide as health economists are estimates of the potential value of healthcare interventions, whether it's a diagnostic test or a treatment. Then people need to make a decision based on the information that we then provide them. So NICE is one example, AWMSG is another, Health Technology Wales is another. They would look to see this evidence and make a decision. And in order to make that decision, there must be some rules somewhere to say what is and what is not cost effective. And by crook or by luck, the sort of the threshold has been set at in the range of £20,000 to £30,000 per QALY. So they determined that the NHS should be able to provide access to treatments with an average cost effectiveness of between £20,000 to £30,000, meaning that the average person for each QALY that they would experience, it would cost £20,000. Now, in reality, people may only experience half a QALY and incur £10,000, but that equates to the same ratio of £20,000 per QALY. So it's what the NHS should be willing to pay for additional improvements in health outcomes from new technologies.
Fab, that makes much more sense. Thank you.
Thanks, Dyfrig. That was a great talk. It's really interesting. I was just wondering about the people who experience quality or the EQ5DL, where they experience life worse than death. Is that the kind of thing, you know, if we're talking about cancer care, some people want to end their life peacefully and quickly, and others just want any length of additional time. You're not obviously doing the judgment. You said you're informing, not making the decisions, but is that a concern or a consideration at all, where people have a very challenging experience, but doesn't mean they don't want to carry on?
Yes, I mean, what we would do, we would administer these questionnaires to a sample of patients. So I think health economics is very much aligned with public health than it is to individual care of individual patients. And so on average, we can determine that, yes, some people score this negatively, some score it positively, even though that to the outsider, there'd be the identical health profile. People place different preference on it. And so because of that, we focus on the mean value. So we're looking at group means in effect. We consider the distribution on the mean. We do the statistical tests as you would do with any data, but we focus on the average impact that treatments may have on people's quality of life or the utility score. So yes, there will be a variation in how people value the same state of affairs, but we try to consider that in the uncertainty in the cost effectiveness ratio. So we're not making judgments as to when care ought to be stopped, etc., in those kind of critical periods in people's lives. We're just making available the evidence in a transparent way, and quite explicit in terms of whether it represents good value for money for the NHS. I think there's always that flexibility of individual patient care, being removed from that equation. We're looking at making decisions for populations receiving a given treatment or intervention.
So Dyfrig, I noticed people are leaving and we're just running over time. I've just got one question about, so what we're talking about here is the NHS a lot of the time. What happens in other countries? And when you're starting to have to deal with, I don't know, European or global health, or,
Yeah, so well, each country has its own system, first and foremost, because the methods align with the way in which the health service is delivered and who funds it. So in the States, for instance, where insurance underpins most things, or it doesn't, in the sense that you're not covered at all, then it boils down to how much you can pay out of pocket in some populations, in some contexts. There is a separate group there that does evaluate cost effectiveness based on the same principles as I've outlined here, but that doesn't inform decisions necessarily. So in certain countries, in Germany, they look to see within a class of treatment. So these are comparable treatments or interventions for a given disease, and they try to assign how valuable they are based on their merits without looking beyond that. In the UK, we're quite focused of comparing a new treatment for breast cancer with an existing treatment for colorectal cancer versus a treatment for heart failure, right across the piece to make it as fair as we can. And that's not the same in every country. Having said all that, many countries do use the similar methods to those in the UK, though they may apply different thresholds for cost effectiveness, etc., understandably, because GDPs will differ between countries, etc.
Thank you. It's totally fascinating. Okay, so thank you so much. And thank you, Emily, as well, for kind of contributing. And Emily is one of our award holders, so I'm hoping that doing all the methodological work, and hopefully one day we'll be able to get Emily to tell us more about her work. Sarah's just posted in the chat if we asking for some feedback, and we've got a short form in the chat to help us design future webinars, and we'll also try and email that out to people as well. But thank you very much, and we look forward to seeing you in April. Have a nice afternoon.